Good morning. I would like to start by thanking the NHO for asking me to update on NTAG at this year's conference, and indeed for their support for NTAG since its inauguration in January 2020 and the time in between. NTAG is a stakeholder representative group for all of those who are involved and interested in transfusion across the country, actively supported, as I've said, by the NHO in the last 2 years and by the IBTS and our three pillar societies across the Irish Haematology Society, the Academy of Clinical Science, Laboratory Medicine, and the relatively newly convened National Haemovigilance SIG. We've all been occupied and consumed in the last 2 years with the pandemic, managing the pandemic, and of course it has derailed the original plans for NTAG. And over the past 2 years, we have been focused really on sustaining the blood supply. And as I've overviewed here, and NTAG has played a very significant part in that. However, I want to talk today about other work that has been happening in parallel, where we were invited to be part of a guideline development through NEC, the National Clinical Effectiveness Committee, on intraoperative life-threatening hemorrhage. This arose from a tragic case and was ministerially commissioned with this defined scope for the RCSI to enable the guideline development, with Mr. John Hyland chairing it and Ms. Miriam Kennedy as the project manager. This is a major practice change for 52 hospitals across the country. And today I'm going to focus on the transfusion aspects of that. So NEC guideline development is a standardized national approach, stakeholder engaged, and we were looking to be informed by evidence locally. I'll talk a bit more about that later. It was a very active public consultation when the draft guidelines were actually developed, and that was through last summer with 39 submissions and further follow-up communication across the various groups, particularly the pillar groups, including the National Haemovigilance SIG. There were international expert reviewers, including Simon Stanworth for transfusion hematology, who is leading the revision of the BSH guidelines. So we were in a position to submit to NEC in October last year a total of 17 recommendations. And we have recently been advised that NEC has actually approved this guideline, and this will be launched shortly. The implementation plan is multi-annual. We can't get it all done immediately, but there is a significant education and training demand for this, and we've looked for a national approach to some of this also. Very conscious that this is a defined circumscribed scope. So we have work ongoing through NTAG for other clinical scenarios, and Mr. Morgan McMonigal will speak to this shortly. In addition, Dr. Brigitte Byrne is chairing for the Institute of Obstetricians and Gynecologists and the National Women and Infants Health Programme, a PPH guideline, where we're looking to have a consistent national approach to life-threatening hemorrhage across all clinical scenarios across the country. And the RCSI invited participants, stakeholders, to engage in this guideline development. And of course, at that time, the National Haemovigilance SIG was not in existence. So in learning and looking at the evidence that is set out in the guidelines that have been developed, and while this was in a trauma-focused guideline, I thought this was very powerful. The greatest outcome improvement can be achieved through education and the establishment of an adherence to local clinical management guide algorithms. So looking at a national approach, in the recent European Blood Alliance survey showed that there was a national approach in Denmark and Germany, and in Wales there has been a national approach for PPH. In the intraoperative setting, we were looking again for what evidence is out there about what is the burden of this, what are the issues around intraoperative life-threatening hemorrhage. So we went to the National Comparative Audit in the UK over October of 2018, where there were over 800 events considered. 23% were intraoperative, most of those 78% unexpected, majority out of hours, and quite a significant number of patients, 16% were anticoagulated. We undertook a survey for across the Irish countries for the evidence around 2018, looking at structure, looking at processes, and looking at outcomes. So we had feedback from 40 hospitals that have significant surgical activity and a further 12 off-site hospitals. So that's where we come up with our 52 total surgical sites that are relevant for this guideline. There was a wide variation in policies and practices from initiation to the actual management of massive hemorrhage. And we actually had outcome data from 22 hospitals identifying for us that 20% of events were intraoperative. The mortality rate was just over 10%. And significantly, particularly in the maternity hospitals, these events occurred out of hours. It was over half of those in level 3 hospitals and about a quarter in our level 4 hospitals. And we turn to hemovigilance. Hemovigilance is such a tool for us to learn from. And looking at SHOT and their clear focus on every minute counting, and looking at particularly 2020 output reports, 133 reports where 80 were emergent or urgent, and 25 were associated with the massive hemorrhage protocol activation, with 12 patients dying in these associated with these reports. What were the main problems? Poor communication, delayed recognition of concealed bleeding and of the severity of bleeding, lacked knowledge, failure to follow correct procedures, and they note a concern that these reports are increasing. We have developed 17 recommendations, and 13 of these were relevant or related to hospital transfusion activity. And we've looked at and brought in new consideration in the management of life-threatening hemorrhage. We've included transfusion testing and laboratory testing and turnaround times in the consideration of what's a safe surgical site within the national framework for that. We are introducing a national poster looking at patient blood management aspects. Within theatre, how are people aware, made more aware? How are they prepare for an unexpected life-threatening hemorrhage? The value of training and drills, key role of communication, the importance of monitoring and serial testing and all the aspects of testing, resuscitation of transfusion, a standardized approach, universal approach to transfusion resuscitation, the importance of audit, a data set for audit, the importance of reviewing that audit, and looking at arrangements for medical scientists, particularly out of hours, and having a safe surgical site as an off-site facility where there isn't a transfusion laboratory. So Miriam Kennedy has kindly loaned this slide to me, and looking at the implementation of the guidelines, most of the transfusion guidelines can actually be managed in the first year or two in terms of getting our posters and our policies and procedures in place, looking at the surgical aspects in theatre, also looking at our hemostatic tests and having our turnaround times, and again, having our debrief and case reviews in place for our learning. We took the view of a clinical crisis, so looking at an anticipatory definition of life-threatening hemorrhage. From a clinical point of view, a shocked patient, a patient who has ongoing bleeding, showing a clinical impact, rather than the retrospective considerations that have been and definitions that have been in place previously, usage of components over time, etc. We also had support in looking at a systems approach, and these are just some of the examples of some of the issues that have been considered. The prevention of this, both in theatre and before theatre and pre-operative assessment. Preparedness, that the surgical site is actually prepared. Sample acceptance policies, that we prevent error and allow concessionary release. Component support by location, we know what we have, where is it located, how quickly can it get to theatre. Looking at our documentation, that we all have consistent documentation and developing tools to help hospitals write up their own policy and protocols. The national poster I've mentioned, and a data capture set for audit. The role of education and training, again, addressing these within our guidelines. The debrief, a recommendation around the debrief, and making that wider than theatre where that can possibly occur. Audit again on a national and a local basis. It's a clinical crisis. So we had assistance from human factor experts to develop a recognition of these human factors and bring these into our guidelines. So helping that early recognition of major blood loss, communication with clear activation, a statement that I'm activating life-threatening hemorrhage protocol. It's a code red, it's life-threatening, that we have a common language across the country. We agree a coordinator or a team leader, and they in turn appoint a communication lead. And the follow-up is prompted by the national poster. For those who are taken unexpected, unawares that this is going to happen and find it difficult to react very quickly, the national poster is a good prompt. And of course, like any crisis event, it must be stood down. So the approach to management, we have a protocol for a medical emergency. We activate it with a code red. We control bleeding. We're assessing the patient and resuscitating the patient. And then we have hemostatic resuscitation. So that pathway of communication has to be very clear. We have a nationally adopted language. We've closed communication loops, so it's very clear what's asked of the laboratory, what the laboratory information that's being passed on, very clearly passed on. And equally, if the laboratory and when the laboratory is in communication with the IBTS distribution site, that's closed communication as well. Optimizing laboratory response, both for testing and components, and the use of near-patient testing where that is available. We're aware of the physiological effect. We know we're going to get this effect with about a 40% blood volume loss, and probably a little earlier in some patients. We know this will be associated with a coagulopathy. We want to optimize coagulation factor replacement because it is used. There's activation of fibrinolysis, and of course there's hemodilution with resuscitation. And while it's less severe than in other circumstances like trauma, it has to be managed. We want to get tissue oxygenation enhanced to prevent coagulopathy as early as possible. So when we're looking at our components, our red cells that we're aware of, what's available in Ireland now, our plasma is SD plasma at this point, our platelets, being aware that they're not always available in every hospital in Ireland. And indeed, if one unit is used, one therapeutic dose, having to make arrangements to have a follow-up therapeutic dose available as well. Fibrinogen, a role very early on. It's depleted very early on, and having that available, quickly available in the right setting. And the use of tranexamic acid now, again, looking at the evidence for the various circumstances for trauma, the woman study for PPH, etc., and reversal of anticoagulation. So getting in hematology support quite early on there. Patient monitoring, again, we're trying to prevent coagulopathy and resuscitate this patient. So we're looking at clinical, including cardiac, but also metabolic, and its importance in terms of preventing coagulopathy. Blood sciences laboratory and near patient testing, that we have an accurate sample, we know who the patient is, and that we can get good turnaround time so that we can get updates as quickly as possible to convert from empiric massive hemorrhage pack support into what's relevant for this particular patient circumstance. So we need to have those tests ongoingly available to us. If we're using near patient testing, that should be compliant. We have version 6 of the guidelines published last April, and hospitals should be in compliance with those when using near patient testing. We have developed a number of tools, including a framework document to assist hospitals set out what their policies and practices are and have them in compliance with the NEC guideline. So the framework document refers to organizational, clinical, and laboratory approach. It identifies structures and responsibilities in developing those. It has a standardized approach in the national poster. And each hospital has to set this out. There's a requirement that each hospital must have this documentation in place. The Hospital Transfusion Committee will have a key role here at the hospital transfusion team, and we're aware they vary across hospitals. So it's again for each hospital to set out what's in place in this hospital, who's available, what roles are available, and what are their responsibilities. The framework document also looks at training and drills. It notes that there will be national support There will be video material available, and hospitals need to keep abreast of when this actually becomes available. It very much supports periodic drills across those clinical scenarios where life-threatening hemorrhage occurs. Again, the KPIs for training, the Hospital Transfusion Committee has a role here, again with audit, with training, with drills, assisting these. And the Hospital Transfusion Committee will report into the overarching Transfusion Committee. The national poster is a key tool that has been developed. This firstly empowers clinicians to actually activate it on a clinical basis, setting out an algorithm, specifies where components are available, how near it is before they're actually going to be in theatre, and clear arrangements for transfusion support for off-site facilities as well. So this is the poster. And we have three main aspects to this after the activation. We have the clinical management, we have the communication, and we have the blood transfusion management. And with that, we're looking at immediately having access to emergency blood support, and then supporting with empiric transfusion. Our massive hemorrhage pack is going to be a 4:4, a 1:1 ratio of red cells to plasma, so it can be universally applied. The use of tranexamic acid, obviously, very early on, and then topping up with fibrinogen with every blood volume loss. Calling in for platelets, just making arrangements early on, not waiting for the platelet count to get down to 50, but once it's running at 100 and it's ongoing, looking to have platelets available and knowing where they will be available. The other main aspect, as I've said, is setting out on the poster exactly where every component is in your hospital and how quickly they can be accessed. We've acknowledged that we're not in a position to come to a recommendation in relation to cell salvage, not universally applied in Ireland, very little availability out of hours, and the evidence doesn't support at this stage that it improves mortality. So that is something to be developed further. The same with our audit. We, at this point in time, will be recommending to NHO or applying to NHO that there should be a national audit in relation to life-threatening hemorrhage. Medical scientist resourcing is going to have to be addressed, and VHAs at this time, again, we're not seeing that this actually is improving mortality, so we're suggesting that this again is done in a controlled environment. Implementation, the responsibility of the CEO and the general manager, but we all have a part to play. We're all key players in actually having this guideline implemented, having it effective in enhancing practice, and in terms of audit and review. So their governance arrangements differ between different hospitals, and they again are specified in the policy documents. And these guidelines actually align very well with the SHOT recommendations. These are set out in last year's report, SHOT annual report, involving clinical staff in training for recognition, knowing how to activate it, having our protocols very well set out, engaging staff in drills, laboratories having robust procedures, communication channels functioning well, correct pathway for activation, contacting all relevant staff, including the porters, and that they're regularly audited. So we feel that we're well aligned with the SHOT recommendations in the NEC guideline that will roll out in the next month or so. We do have an ask, of course, of the National Vigilance Office here. It would be a huge assistance to the implementation of this guideline and the enhancing of transfusion practice in relation to life-threatening hemorrhage if reports could be collected of delayed transfusion. So that's our ask of the NHO, and thank you all for the opportunity for speaking today.